and I'm very happy to welcome you to our first 2016 Watch webinar. Today we are going to be going over the title of our webinar is Taking Care, Understanding and Addressing Mental Health Among Women Living with HIV, and we are very excited to have a large group who registered for today, and so we're going to wait for just a minute for everyone to get on the webinar before we get started. Also, for those of you who have joined by phone, if you click on the phone icon at the top of your screen, you'll see a 3-digit PIN that is underneath the access code that you've already punched in. And if you can dial in on your phone just the star plus the 3-digit number and pound, that will connect you to your webinar screen and will allow more people to join today's webinar. Great, we're seeing a lot of people check in on the chat, which is great. We love to see where everyone is from. That helps our presenters know who's on and where you're from. We have a very diverse group of people from all over the U.S., as well as I see Bose from Nigeria checking in, and Joe is from India, so that's great. Thank you. Okay, once again, this is Krista Martell from the Well Project, and we will be getting started in just 1 minute. And as for those who have not participated in one of our webinars before, typically we save the question and answer period for the end of the webinar. So feel free to type in your questions during the webinar into the chat box, and we'll keep track of those and pose those at the end. Okay, great. Well, I think we will get started now since we have a full agenda. So first, just a brief introduction of the Well Project. We are a nonprofit organization with a mission to change the course of the HIV/AIDS pandemic through a unique and comprehensive focus on women and girls. And we have been leveraging technology since 2002 to improve health outcomes and increase the quality of life for women and girls living with HIV. So our primary focus is to provide accessible and comprehensive information, as well as community support and advocacy building. And the Watch series that was launched in 2015 has been a big part of our advocacy development and training. So we are excited about the 2016 series, which will be different from last year's in that it won't be an 8-week concentrated series, but we will be rolling it out throughout the year. And I will talk a little bit more about that in the next slide. So WATCH stands for Women's Advocacy and Treatment Coalition on HIV, and it's an ongoing HIV treatment advocacy and capacity building webinar series. And as I just mentioned, the 2016 series will take place throughout this year and will include 5 to 6 webinars. For those interested in receiving a certificate of completion, you must participate in the live webinars or view a recording, as well as take the pre- and post-test and a final evaluation survey at the end of the series. And all the webinars will be recorded, and we will be posting them on our website approximately a day or two after today's webinar for 1 month. So now I am honored to introduce and provide you with our presenters for today. We have Vickie Lynn, who is a doctoral student and instructor at University of South Florida, Tampa, USF, and she also is a member of the Community Advisory Board for the Well Project and a Girl Like Me blogger. And secondly, we have Dr. Edward Machtinger, who is a professor of medicine and director of the Women's HIV program at the University of California, San Francisco. And again, this is Krista Martell, the executive director of the Well Project. So about this webinar, it will last approximately 90 minutes, again with the Q&A at the end, and we ask that you use the live chat box on the left side, as many of you already are, to enter in your questions while someone is talking. And we will put the questions in a queue and put those to the presenters at the end of the webinar. So as I mentioned in the beginning, we have a lot of people registered for today, and so if possible, in order to be able to provide as many spaces as possible, if you can click the phone icon at the top of your screen, and under which you'll see the phone number and an access code, and then there's an audio pin that is for you only. And if you can dial the star with 3-digit number and the pound sign, that will connect you to your webinar screen and provide more space for people to attend today's webinar. Okay, and everyone's lines are muted until the Q&A. We will see how many questions we have. If we are able to open up the phone lines, or if we have a lot, we'll try and get those all out to the presenters. So, okay, and now I'm going to hand it over to Vickie Lynn. Thank you.
Hi, everybody, and I'm so grateful that you guys are here and glad you've taken time out of your day to join us. I want to take a moment and introduce myself. I've been living with HIV for 30 years. After contracting HIV in 1985 and diagnosed with AIDS in 1991, I had little hope of ever having any sort of real life. Due to deteriorating health, I ended up losing my job, my home, access to care, and my hope. After living on the streets of Tampa Bay for about 6 months, I was finally offered housing through a local community AIDS service organization. I regained access to care and treatment, and with the development of new medications, my health began to improve. I remember thinking, if I had a second chance of life, what would I do? For some reason, I decided I wanted to go back to school just so that I could help others. I earned my AA, then my bachelor's degree, a master's in social work, then a master's in public health, and I am now currently working on my doctorate degree in public health, specializing in behavioral health. I have worked on many service boards, marched with ACT UP in the 80s and 90s, volunteered with various organizations, and I continue to advocate for human rights, access to health, and women's issues. My academic research involves examining integrated care for people living with HIV, which I'll talk a little bit about at the end of the presentation. And integrated care is just a model of care that holistically addresses the physical, mental, and social service needs of people living with HIV by using collaborative, interdisciplinary teams of professionals. So what is mental health? Mental health refers to our emotional, psychological, and social well-being, all of which can affect the way we think, feel, and act. Mental health also helps determine how we handle stress, how we relate to others, and how we make choices in our lives. It can also change how we function at work and at home. And good mental health is a sense of well-being, confidence, and self-esteem. People living with HIV are actually at higher risk of developing mood, anxiety, and cognitive disorders. Mental health conditions for people living with HIV can affect physical health, which can make it harder to take HIV medications on time. It can make it difficult to keep appointments. It can even affect our ability to take advantage of our social networks. Mental health conditions can interfere with healthy behaviors and impair our ability to cope with the stresses of daily life. What is important to know is that mental health conditions are treatable, and people who experience mental health problems can get better, and many recover completely. Common mental health conditions for people living with HIV include mood, anxiety, and cognitive disorders like depression, anxiety, substance abuse, and post-traumatic stress disorder. Women living with HIV often have higher incidence of past trauma, which can include gender-based violence and abuse, which Eddie is going to discuss later in this webinar. Krista, do you have the poll question?
Hi, yes. So the first poll question is, I'm going to just make sure, to your knowledge, have you ever experienced any of the mental health conditions listed in the previous slide? Depression, for example, depression, anxiety, substance abuse, or PTSD? We'll wait just a minute while people put their votes in. Okay, so we're going to close the poll up now, but we have around 78 to 79% who answered yes, and 20% who have answered no, 22, 23%.
So those numbers are actually quite normal for people living with HIV and for the general population. Mental health conditions are common, and many people experience these sometimes in their life. And like I said, what's important is to know that there is help available. The prevalence rates of mental health diagnosis in women living with HIV can vary depending on the source of information, but research shows that the rates of mental health conditions are 2 to 3 times higher than those seen in the general population. Women living with HIV are even more likely than men to have at least one psychiatric disorder like depression, anxiety, or substance use problems. As stated earlier, living with HIV puts people at greater risk for substance use and mental health disorders. And living with mental health disorders or substance use problems can actually put people at higher risk for HIV or even reinfection if you're already living with HIV. In one study, it found that 25 to 50% of people living with HIV had a history of substance abuse issues, and 12% actually screened for drug dependence. And as many as 50% screened positive for mental health disorders, with depression being the most common. It's important to note that a high percentage of mental health and substance abuse issues actually go undiagnosed and untreated. Some clinics do not screen for mental health or substance abuse problems. If you think you might have something going on, talk with your provider or other health care specialist. And if you're a provider and your clinic is not screening for these issues, you might want to consider adopting new screening tools for the population you're serving. One of the most common mental health disorders in women living with HIV includes depression. But how do we know when we are just sad or when it might be something more serious? Sometimes we are just sad, and that's okay. However, there's a difference between being sad and having symptoms of depression. So compared to sadness, depression is more intense, it lasts longer, sometimes more than 2 weeks, and interferes with our day-to-day ability to function. So in medical language, depression is a diagnosis based on having a certain number of specific symptoms, but it's not necessarily a normal part of living with HIV. Depression can cause some serious health problems and can greatly impact our physical health. If you have any of these symptoms or are unsure if what your experience is normal, it's important to talk with someone so that you can get the help you need. Here are some other symptoms: changes in appetite or weight, aches and pains for no clear reason, feelings of sadness, guilt, hopelessness, and or worthlessness, irritability, getting into arguments easily, lack of interest or pleasure in activities that usually interest you, having low sex drive, difficulty making decisions or concentrating, changes in sleep patterns, and even fatigue or loss of energy. In addition to these symptoms, you may also notice yourself doing some of the following: not taking care of yourself in terms of grooming, dressing, or personal hygiene, skipping or not going to work, calling in sick, being very critical or down on yourself, not talking to, or not going out with your friends, and not taking part in social activities, crying or feeling like crying more often than normal or often without knowing why, and using alcohol or other substances or recreational drugs more than usual, or using them to numb your pain and hide from your feelings. And sometimes substance use can hide depression, and this happens when we try to self-medicate by using drugs or alcohol so that we don't feel the pain of our troubles. And you might feel depression or anxiety, but substance use actually adds to that. So again, talk with your health care provider. It's important to seek help for both your physical conditions and your mental health conditions. Although many people living with HIV live long, healthy, and full lives, learning that you are living with HIV is life-changing news that can be very difficult to hear and accept. Some people feel overwhelmed, helpless, or unable to cope with the diagnosis. Others are afraid for their future health or afraid of disclosing their HIV status to family and friends. The stigma that many women living with HIV experience may lead to depression, social isolation, and feelings of loneliness. All of these are key elements of depression. Women living with HIV may also experience large life stressors, such as racial discrimination, poverty, violence, being a single parent, and all of these can also lead to depressive symptoms. An HIV diagnosis can simply add to this burden and increase the chances of developing depression. There is also new evidence that HIV itself may contribute directly to depression. Researchers have found that there are biological reasons for this. However, more research is being done, and you'll begin to see some research coming out about that pretty soon. Many studies have shown that there is a direct connection between depression and poor health outcomes for women living with HIV. We seek care less often. We have trouble sticking to our HIV drug regime. If you're experiencing symptoms of depression, you may miss a dose, take the wrong dose, or even take it at the wrong time of day. So not taking your HIV medications regularly can lead to the development of resistance, which makes HIV drugs less effective at fighting the virus. This can cause your CD4 cells to go down and your viral loads to go up, which of course increases the disease progression. Seeking care can improve health outcomes, and it's important that depression be diagnosed and treated as quickly as possible. So some of the treatments for depression that are available include psychotherapy. Electroconvulsive therapy has also been found helpful, although it's not for everyone. It's a very controversial treatment, but it is actually one of the most successful non-pharmaceutical medical therapies for depression. Light or phototherapy has been helpful for some individuals. Cognitive behavioral therapy is widely used. Sometimes family therapy helps, and even medications can be helpful. There are numerous studies that also show exercise is beneficial. There are many treatments available, so it's important to speak with your provider in order to find the best treatment for you. Anxiety is also common for women living with HIV, and anxiety is actually a normal reaction to stressful situations. But in some cases, it becomes excessive and can cause people to dread everyday situations. This type of steady, all-over anxiety is called general anxiety disorder. Other anxiety disorders include panic attacks and even obsessive-compulsive disorders, which is marked by the persistent invasive thoughts or compulsions to carry out specific behaviors such as hand washing. Anxiety sometimes co-occurs with depression, but again, both are treatable, and you should talk with a provider. And some of the emotional signs of anxiety include irrational and excessive fear and worry, feelings of apprehension and dread, having trouble concentrating, feeling tense and jumpy, anticipating the worst, and feeling irritable and restless. And those are the emotional symptoms, but there's also physical symptoms. And those include a pounding heart, sweating, stomach upset or dizziness, shortness of breath, headaches, fatigue, and insomnia. So there are techniques that people can use to help them deal with anxiety, and always talk with a professional, but proven methods include deep breathing exercise, journaling, keeping a journal, writing down the thoughts that are racing through your head. Getting the thoughts out of your head and onto paper can help clear your mind. Exercise helps, walking, kayaking, even gardening. For those of you who know me, you know how much I love gardening, and you see all my pictures on Facebook. For me, gardening brings me peace and a connection with nature that seems to calm my soul. Other techniques or treatments include counseling, or even talking with a friend or family member can help you process some of your emotions, and you can learn new coping strategies to deal with the anxiety. Therapies that you would get from a mental or behavioral health specialist include cognitive behavioral therapy. It's one of the most widely used therapies for anxiety. And cognitive behavioral therapy addresses the negative patterns and distortions in the way we look at the world and look at ourselves. And there's actually two parts to it. Cognitive therapy examines the negative thoughts or cognitions contributing to anxiety. So what are we thinking in our head? The behavioral aspect of it examines how we behave and react to the things that trigger our anxiety. So the basic premise of cognitive behavioral therapy is that our thoughts, not external events, actually affect the way we feel. In other words, it's not the situation you're in that determines how you feel, but it's your perception of that situation. So cognitive behavioral therapy examines our thoughts and our behaviors and reactions to those thoughts and tries to work to change those so that we can reduce our anxiety symptoms. So again, always talk with your medical provider and see if you might be able to benefit from this therapy. So before I talk too much about substance abuse, I want to clarify some terminology for you. Substance refers to any mind-altering chemical, plant, or compound, even prescription drugs or over-the-counter medication, street drugs, and yes, substances can include alcohol and tobacco. Some people would even add caffeine into that category, as it is a stimulant and can be considered a mind-altering substance. What these substances have in common is when we take them, they change how we feel, either physically or emotionally. Substance use simply means putting that substance in our body, swallowing it, eating it, drinking it, smoking, snorting, or injecting. Now, someone may progress or be diagnosed with substance abuse when there is a pattern of substance use that involves serious problems or negative consequences for the users. These problems include, but aren't limited to, not going to school, legal troubles, struggle with relationships and families, and using substances in dangerous situations like driving a car. Substance abuse can progress to dependency, and the word is used most often to describe what happens when the body gets used to or accustomed to a particular substance. Sometimes the body learns to tolerate a substance so that more of the substance is needed to get the same effect someone once had. This is called physical dependence and also means that suddenly stopping the use of the substance will likely cause withdrawal symptoms, and in the case of alcohol, can actually lead to death. It is important to seek medical attention when trying to stop certain types of drugs, including alcohol. Please talk with a doctor if you think you're having a problem and you want to wean yourself off of some of the substances you might be using. So the last phrase up here is addiction, and it just refers to substance use that involves the loss of control, so compulsive use. It's when it continues despite harmful consequences, and people are often in denial and refuse to acknowledge that they even have a problem. Addiction is now considered and understood as a chronic, long-lasting disease of the brain's reward and motivation system. Continued use of substances that alter how we feel can change our brain's chemistry and electrical wiring. In other words, addiction does not occur because we don't have the willpower to stop. It occurs because there's chemical changes within our body when we take these substances. And there's also a fine line between abuse, dependency, and addiction. So please don't get yourself confused with the terminology. Any drug use or substance use can lead to negative consequences, and together with HIV can greatly impact health outcomes. Substance use can and does affect our health and can have profound effect on the progression of HIV. Using and abusing substances can increase viral loads, lower our CD4 count, increase rates of medication resistance because when we're high, we're not taking our medications as prescribed, and we may skip doses. Sometimes when people use substances, they also engage in risky sexual behaviors, which they would not normally take if they were not high. So this puts us at greater risk for reinfection, other STIs, and poor health outcomes. Please, if you think you might have an issue, talk with someone. Find somebody you trust and talk with them. I want to talk briefly about post-traumatic stress disorder, and I'm going to just give you a quick overview, as Eddie will talk more about this in a few minutes. Post-traumatic stress disorder is a mental health disorder that basically includes 4 types of symptoms. So reliving or re-experiencing the trauma in the form of nightmares or flashbacks. Sometimes people are triggered by reminders of the original experience. So avoiding or staying away from people, places, and activities that remind us of the person or the original event. Feeling keyed up, on guard, jittery, or irritable. The body and mind remain hyper-aroused or hyper-vigilant, which can lead to trouble sleeping or being startled easily. Also, there's changes in mood and thinking, depression, anxiety, problems with memory. These often include losing interest in one's pleasurable activities and a sense of being detached from others, and even trouble experiencing a full range of feelings. So PTSD can be very disabling, as it can lead to problems with substance abuse, job stability, and can negatively affect the relationships in our lives. There are proven treatments that have been found to be helpful, and I'll talk about those in a minute. It's estimated that 60% of adults in the United States have experienced an adverse life or trauma event at least once in their life. Traumatic events can be many things, including childhood violence, loss of family and friends, and HIV diagnosis in and of itself can cause trauma for some people, intimate partner violence, sexual assault. Even surviving a natural disaster or having a car accident can bring on post-traumatic stress disorder symptoms. There are many things that can happen that can increase the likelihood of PTSD, and if you have multiple adverse life events in your life, you are at greater risk. So most survivors of trauma have some stress-related reactions after the traumatic event, and that's normal. Most people will begin to feel like themselves again with time and a little help. However, if the physical and emotional reactions do not go away or get worse over time, this may indicate that you're dealing with PTSD which can lead to other physical mental health problems, so it is important to seek help. There are a variety of treatments, including cognitive behavioral therapy, exposure therapy. I always have trouble saying the next one. Movement desensitization and reprocessing, otherwise known as EMDR. And there's even a new treatment called HEART, Accelerated Resolution Therapy. And I actually had the privilege of talking with a researcher who's working with the VA on this brief intervention, and they've had a lot of success with soldiers living with PTSD. Again, if you think you have a problem, talk with a specialist. You guys are going to probably get sick of hearing me say that, but it's so important because there is help available, and we can live wonderful, great lives if we get the help that we need to reduce some of the symptoms we're feeling. And if you're having any thoughts of harming yourself or harming someone else, please tell someone immediately. In the U.S., you can call 1-800-SUICIDE. That's 1-800-784-2433 or 1-800-273-TALK. And if you need to find a suicide hotline near you, you can go to this website, www.suicide.org, and there, on that website, there are U.S. hotlines by state, and then as well as by country. So you can click on the international hotlines link at the top of the page, and it can help you navigate that to find help. Again, please do not hesitate to get help. You all are amazing people who deserve a wonderful life, and there's people who care that really can help. Or if you know someone else who may be going through something, you can help them to find the help they need. So when we experience emotional difficulty, there's no need to suffer. Effective treatment is available, and like I said, the good news is treatment is available. There's other treatments including psychotherapy, social support, 12-step programs, spiritual guidance, medication. There's alternative therapies, or even a combination of these therapies have been found to be helpful for some people. Some of these can be free or low cost. Talk with your primary care doctor, talk with your case manager or a friend. Find the services in your area that you might need to get help. And sometimes asking or even finding help can be challenging, especially for people from different culture or ethnic backgrounds. But find someone you can trust and get the help you need. No question.
Okay. So the next poll question is, have you ever sought help for mental health care? This is actually a two-part question. We'll keep it open for just another minute. Okay, so it looks about 60% have and 40% have not. Okay, I'm going to close up the polls on this. And then the next question is related. If yes, were you able to access the mental health care you were seeking? And this goes a little bit into the access to care that we'll be addressing later. Okay, so we'll close this up in just 1 second, but it looks like the majority, about 80%, are saying that they have been able to access mental health care, so that's good to know. Okay, I'm going to close this vote and hand it back to Vickie Lynn.
Thanks. That is really great that people, are seeking care and they're getting the care they need. That makes me really happy. So one treatment that we often overlook is social support, and it's actually one of the most widely available help. It can be helpful to seek the support of other women living with HIV through support groups or peer counseling. You can visit our online blog for women living with HIV, A Girl Like Me, and read stories from other women and get support there. And social support from friends and family has been found to help people living with HIV avoid depression and cope better with living with HIV. So connecting with others can be helpful to not feel lonely and isolated. Friends and family can provide emotional support, which is important. Sometimes our biological families might not be the best support, so finding people you trust who are supportive is a great gift and asset to have. You know, I have my own biological family, and then I have who I call my chosen family, people who love and support me for who I am, my flaws and all, and so I use them as my social support network. Other treatments include meditation, massage, yoga, breathing and relaxation exercise, and those are all alternative therapies that can help you feel better. Acupuncture and acupressure therapies may help reduce stress and improve our moods. Mindfulness techniques can help you get back in touch, which makes life worth living, and it can help you avoid that downward mood spiral. Some of these have been used in combination with traditional psychotherapies and medication, and it's been shown to be effective. And also just having good nutrition and engaging in physical activity can be beneficial. So I want to talk briefly on why integrated care is so important. You know, our current system of care is fragmented and often treats patients in silos. So meaning, you know, care is divided among different healthcare professionals and different agencies who do not actually communicate with each other. So treating patients in silos actually ignores the interaction of mental health, substance use, and HIV. So the key point is not only do large numbers of people living with HIV have many health problems, but those problems interact and make each other worse. Research shows, for example, that problems with substance abuse make mental health and HIV care more difficult. HIV, mental health, and substance abuse and other medical conditions interact and exasperate each other. Neglecting or ignoring any of those conditions can lead to worse health outcomes and premature death for women living with HIV. So to provide the best services possible for patients, providers need to be able to identify and treat both HIV and other mental conditions that can compromise clients' well-being. And that includes, like I said, mental health and substance abuse issues, as well as the physical. So we may see improved health outcomes by holistically addressing the physical, mental, and social service needs of people living with HIV by using a collaborative, interdisciplinary team of professionals. This can help improve health outcomes, increase quality of life, and ultimately reduce transmission of HIV. And this is what integrated care can do. Integrated care is defined as the care a patient experiences as a result of a team of primary care and behavioral health clinicians working together with patients and families using a systematic and cost-effective approach to providing patient-centered care for a defined population, and in this case, it's women living with HIV. So integrated care can address mental health and substance abuse conditions, health behaviors like stressors and crises, stress-related physical symptoms, and ineffective patterns of healthcare utilization, as well as social service needs for people living with HIV. So we're beginning to see clinics throughout the United States provide integrated care services, but we still have a long way to go. And that's my research area, and I hope to be able to bring you guys more when I complete my research in a year or so. So that's the end of my slides. I thank you for listening.
Wonderful. Thank you so much, Vickie Lynn. That was an amazing overview of a very important topic as it relates to women and people living with HIV. And now Eddie is going to speak a lot more about this and from the provider perspective, as well as provide insight into a model of care that would really help solve some of these issues. So, Eddie, I'm going to hand it over to you. Thank you.
Hello, everybody. I'd like to thank Krista and Jenna from the Well Project for inviting me to participate today. I'd also like to acknowledge the collective wisdom of all of you on this webinar. I'm really honored to be here as a provider. I'd also like to acknowledge Vickie's just talk on integrated care because in many ways it sets a really good stage for what I'm going to talk about. And I don't actually probably even need to give my talk now. That was so good. But my talk is going to be on one aspect of mental health care that really does relate to integrated care, which is trauma. And in my short talk today, what I'd like to express is that women living with HIV are not faring nearly as well as they should be, even when they're fully engaged in care. And so, for example, in our program, which is a good program, and I'll talk about it, even among patients who are engaged in care and have an undetectable virus, if you scratch just a little bit beneath the surface, half of my patients are depressed, 40% are using hard drugs, most don't feel really safe being out about their HIV status, which makes it really hard to make real friends and relationships and find the support that people need. Many are involved with abusive partners, and very few are working despite wanting to, and a surprising number are dying. And remember, this is, in a care condition or a condition HIV, which is a fully treatable chronic illness. And so I've come to believe that the services that we offer in our primary care clinics are mismatched with the actual needs of women living with HIV, their families, and communities, and don't provide the healing that many people need. And based upon our research and experience, I believe that the missing ingredient in the care of women living with HIV is a healing response to recent and lifetime trauma that is so common among women living with HIV and is the main reason, more than HIV itself, why so many women are struggling and even dying. And so because it's possible to heal from trauma, I believe that we have a huge opportunity to fundamentally improve the care and lives of women living with HIV by helping care providers and also women living with HIV understand and respond to recent and past trauma. So one more thing before I start. So Vickie talked about some pretty heavy stuff, and I'm going to be talking about trauma. And it's bound to bring up difficult feelings for many of us because recent and past trauma is so common. And I'd say that not just for women living with HIV, but for their providers as well. Like many of us went into this field, it wasn't like a random thing. I chose to become an HIV doctor and a trauma expert. Most of my colleagues have experienced some fairly profound trauma themselves. And I very much want everyone on this call to take care of themselves today. And so if you need to step away from the webinar at any time and get a glass of water or take a break, please do so. Please also know that in addition to the suicide hotline that Vickie showed as part of these slides, I'll provide resources at the end of my talk if you need to talk to somebody about trauma that you are experiencing in your life right now. So in this talk today, I'm going to talk about three things. And that's one, how we came to understand that healing from trauma is a key to health and well-being for women living with HIV. Two, how partnerships and connections with other people and organizations are an excellent way to make this happen, to heal from trauma. And then three, to imagine a primary care setting that is a healing experience instead of just a treating experience. So I just want to briefly describe the clinic in which I work. I'm very proud of it. It's called the Women's HIV Program at UCSF. It was one of the first programs in the country that was designed specifically for women. Prior to its start in 1993, the women were coming into a program that was designed for men. And, there were beefcake guy posters on the walls. There was mostly gay men and gay nurses and gay doctors. And it just really further stigmatized women. And it didn't have the services that many of the women needed, and most of the women weren't out. And so they really struggled in that clinic and didn't end up getting the referrals to mental health and social services and gynecology that they needed. And so this clinic put together a one-stop shop that is now more common, but not common enough throughout the United States and throughout other countries, and it includes primary care, gynecology and obstetrics, a pharmacist, social work and case management, therapy and psychiatry, a hot breakfast, and a number of partner agencies that work together with us in clinic. And it's a Ryan White clinic, U.S. Ryan White funded clinic for low-income individuals. Most of our patients are women of color. There's 20% Caucasian. We have 15% transgender women. We have a wide age range of patients from 15 to 71. We used to take care of kids, but there's so few kids now getting HIV in this country that our youngest patient is now 15. Most are marginally housed, very low income, and most of our patients are really kind of complicated, having a number of medical diseases and having psychosocial stressors in their life. So before I go to the next slide, as you know, many women living with HIV, despite all of these services, still die, despite the fact that HIV is now a completely treatable condition. And it was by thinking about these deaths that we began to understand the impact of trauma on the lives of our patients. And so any time somebody in our program dies, we have a case conference with all of our providers to learn from what happened. And so these are the 10 most recent deaths in our program. And I just like to list them. These names are not real names, they're pseudonyms, but these are real patients that the diagnoses are based on. So 2 died from being murdered, 3 died from suicide, 3 died directly related to addiction, 1 died from pancreatic cancer, and 1 person died from an opportunistic infection after becoming hopeless and stopping her medicines. We knew these women really well, and they were all quite different individuals. But their stories are all united in having lifelong histories of trauma that contributed to their becoming infected in the first place and then led to their deaths, literally in the case of Rose and Amy, who were murdered, and then through substance use, depression, and hopelessness in most of the others. And it's important to note that all of these women were fully engaged in care at the time of their deaths. So I'd like to highlight 2 of these women who died to show the impact of 2 different types of trauma, which is intimate partner violence and lifelong abuse, and how those different types of trauma are sometimes those are manifested very differently, and it helps to understand the breadth of different types of trauma. So Rose was a 54-year-old African-American, beautiful, soft, damaged, but resilient spiritual woman who came into our program to get stronger and stay safe. And we tried our hardest to protect her from escalating vicious abuse from her husband, which was really obvious that she was very open about, and we tried so hard to help her escape from. But in the end, he lured her away from where she was hiding and killed her, likely because he knew that this time she was actually trying to leave him and would leave him. Now, this is different than Pebbles. So Pebbles, who's number 10 on this list, I met Pebbles when she was 15 years old in the emergency room when she came alone because she was getting very sick from something called PID, pelvic inflammatory disease, which is a pelvic infection from a sexually transmitted disease. So she's 15 years old, she's alone in the ER, and she was tested rapidly for HIV at that time, and it was positive. So she got a disclosure alone at 15 in the ER. And she had a lifelong history of trauma and loss. Her mom was addicted to crack cocaine and died when Pebbles was 17. Pebbles spent most of her early childhood in the juvenile justice system and in foster care. And she died when she was 22 from something called PML, which is a completely preventable brain infection. Because despite great efforts to help her, she could just not adhere to her HIV medications. And the death of Pebbles, to me, is an example of the hopelessness that results from lifelong trauma. And before Pebbles died, she allowed us to have a psychiatrist perform what they call a neuropsychiatric evaluation to better understand why she struggled so much with medication, taking her meds. And one paragraph stood out to me in it, and I'll just read the paragraph to you. Pebbles is apt to find the world and all of its demands overwhelming. Life has seemed beyond her control for a long time. She does not have the role models that are facing similar medical situations to gain encouragement and support from. After so many losses and so many bad experiences, Pebbles simply does not believe that the effort necessary to take all of her medicines will really change her life situation. And so she didn't, and she died. And that to me is an example of the disempowerment and what we call low self-efficacy that comes from so much trauma. After Rose died, we were really distraught and convened a citywide group of the many agencies who worked with and loved her to learn from what happened. And we realized that our clinic, and really our whole care system, was unprepared to deal with the imminent danger she faced, and didn't have services to help her recover from the repeated abuse she had sustained and gain the self-confidence and social support to leave this guy, her husband, a long time ago. And so at that time, we committed to perform the research and the advocacy needed to change our program to meet this need for our patients and providers. Vickie defined these terms really well, and so I'm just going to go through them very quickly. I think it's really important to understand definitions because there's a lot of people talking about trauma now, which is great, but it's also a little bit confusing. And then also when you name things, you can develop a response to them. Like when things aren't named, things can become very confusing and we can't figure out how to reckon with them. And so this is a definition from the federal government. Trauma is an event, series of events, or set of circumstances, such as physical, emotional, and sexual abuse, neglect, loss, community violence, and structural violence like racism, sexism, homophobia, transphobia, xenophobia, or war that is experienced by an individual as physically or emotionally harmful or threatening and that has lasting adverse effects on the individual's functioning and physical, social, emotional, or spiritual well-being. So that's kind of a mouthful. But it's basically trauma as capital T. It includes, it's fairly broad of the things that can be very traumatic events. Complex trauma is repeated trauma, and this, unfortunately, is more common in women living with HIV. It's not just one trauma, but it's repeat trauma, physically or emotionally, like repeated childhood physical or sexual abuse, or witnessing or experiencing long-term intimate partner violence. Vickie did a good job explaining what post-traumatic stress disorder is, which is a result of this trauma, and it includes these four symptoms of re-experiencing the traumatic event, avoidance of situations that remind you of the event, negative changes in the way you think about yourself or other people or the world, and feeling very anxious and keyed up. On top of that, there is this definition or diagnosis called complex PTSD. And this was a real epiphany for me. And complex PTSD is a result of complex trauma, repeated trauma. And it includes all the symptoms of PTSD along with trouble regulating and handling emotions and relationships and feelings of low self-worth and powerlessness. And to me, this really was a very helpful definition because it helped explain why some of my patients were struggling so hard with relationships, with crack addiction, why so many people were so reactive, and why our waiting room could sometimes get so loud. And it was very helpful to not think of them as having personality disorders, but having instead complex PTSD, which is indeed very treatable. So the next four slides, I just want to say, are filled with some data from studies we did. So I'd ask that everybody hang in there with me because they're actually pretty simple if you just look at key parts of them. And in fact, I think it's good to look at slides like this so that people don't get intimidated by typical science and data slides because it's important to know this information to take better care of ourselves and advocate for others. And so here I go. So first, we wanted to see if the rates of trauma experienced by women living with HIV in our clinic were representative of the rates of trauma experienced by women living with HIV throughout the United States. And so what we did is something called a meta-analysis, where we took all of the papers that described rates of trauma and combined them into one data set, because so many of them had so many different measurements and numbers relating to the rates of trauma, and came up with an estimate that was a more representative estimate of the rates of trauma throughout the United States. And I'm just going to point out three specific categories of trauma of the many that we looked at. So on this first slide here, I've circled intimate partner violence. When you look at prevalence, it's kind of a synonym with a rate. And so 55% of women living with HIV have experienced intimate partner violence. And that's compared to the already high prevalence, but it's twice the rate of the already high prevalence of 25%, 24.8% in the general population of women in the United States. So twice the rate. 61% of women living with HIV have experienced sexual abuse, which is really kind of a shocking number, which is 5 times the rate of 12% in the general population. And 30%, almost 1 in 3 women living with HIV have PTSD currently, symptoms of post-traumatic stress disorder now, which is 6 times the rate in the general population. So the impact of all this trauma on the lives of women living with HIV can be really devastating. A lot of research by our team and many others has shown that recent or lifetime trauma is associated with getting HIV in the first place. A study we did showed that recent trauma is linked to 4 times the rate of HIV medications failing. It's linked to faster disease progression, more hospitalizations, and almost twice the rate of death. I'd like to show one slide that many of you may be familiar with called the HIV care continuum. And the categories on this graph are the parts of care that the government considers vital for all individuals with HIV. And it's first being diagnosed with HIV, then linked to care, engaged in care, prescribed HIV medicines, and then becoming virologically suppressed. Trauma has a negative impact on each of these elements of care. If you experience recent or past trauma, you're far less likely to be diagnosed, to be linked to care, to be engaged in care, to be prescribed ART, or to be virologically suppressed. But the continuum ends with suppressed viral load. And I have a pretty strong issue with that, because it's as if that alone is enough to make a woman healthy. And I believe that the care continuum is missing a crucial final category, which is the health and well-being of women living with HIV. It should include information about violence, substance abuse, depression, and even death, so that clinics for women living with HIV are held accountable to help address these issues with the same energy that they focus on HIV medications. And I think we're moving in that direction, but I think we need to move there much quicker, because most deaths of HIV-positive women have nothing to do with HIV. We know from the Women's Interagency HIV Study, which is the largest study of women living with HIV in the country, that only 1 of 6 deaths in their most recent year were from HIV. And in our clinic, over the past decade, we had the exact same statistic. 1 of 6 deaths over the past decade were from HIV/AIDS. Most women living with HIV are dying from violence, depression, suicide, substance abuse, and a variety of medical illnesses like obesity, diabetes, heart and lung disease, the majority of which are associated with trauma and PTSD. Okay, now that's all maybe helpful to know, but not totally light and happy. And so I'd like to go to something that, we're going to a poll question first. But I was just going to say, I'm going to get to something that's a little bit more solution-oriented.
Okay, so just a question that we have. So do you consider viral suppression to be your ultimate goal in HIV care? Okay. So it looks about 70% say yes, and 23 to 24% no, and about 5% is I'm not sure. Okay. Thank you. We'll close the polls now.
Okay, that's a really interesting poll result, because I have, maybe we can talk more about that in our discussion later, because I am pretty fixated on this issue that we need, that virologic suppression is so key, and it's changed the world to be able to have these HIV medications and to have the HIV be a treatable chronic illness. It's made such a difference, and the people who didn't have access or don't have access to them have been the people that do have access to them have been so fortunate. But that those medicines are far from enough for women living with HIV and transgender women living with HIV. But I'd like to change now from all of the problems caused by trauma to how we can do something about it. And over the past number of years, I've come to understand that the most effective response to trauma is to reduce isolation. So many of us with histories of trauma and HIV keep it secret, and that leads to a lot of darkness. And I've learned that a lot of healing can happen by reducing isolation through partnerships with other people who understand trauma and HIV. And for you, that might be your doctor or nurse, a therapist, a peer support group. And this has also worked for me as someone trying to overcome trauma for patients in our clinic. And I wanted to share with you two partnerships that have helped our clinic move from one that just treats people's HIV to one that really genuinely helps them heal. And the first partnership I'd like to share is one with Nana Khanna and the Positive Women's Network. And from Nana, I've learned just so many things and been so inspired. And first, in everything I've done, I now have guidance from people with lived experience, women living with HIV as my primary guide. I've been introduced and mentored about the power of political action, and her group has provided our patients access to sisterhood and leadership training, which has been really crucial. And together, we convened. So I asked Nana to help us develop a new model of care in our program that we are calling trauma-informed primary care. I really didn't know how to best approach healing from trauma in the context of a primary care program. And so together, Nana and I convened a working group of 27 leading national policymakers, trauma experts, and advocates from the government, military, academia, clinics, community organizations, and included a number of women living with HIV, to identify the building blocks to develop a practical model of this trauma-informed primary care that addresses both intimate partner violence and lifelong abuse. So first, we needed to identify what are trauma-informed values that would really guide everything we do in clinic. And so these are 6 trauma-informed values that this is, again, from the federal government agency, SAMHSA, that is really charged with this. And these are the values that I strive to inform everything we do in clinic. Safety, and this is for patients and for providers, just a whole overall vibes of safety, trustworthiness and transparency, peer support, collaboration instead of hierarchy, empowerment, voice, and choice for patients and staff, and a cultural, historical, and gender understanding. And then the definition of trauma-informed care or trauma-informed program is a program, organization, or system that is trauma-informed, realizes the widespread impact of trauma and understands potential paths for recovery, recognizes the signs and symptoms of trauma in clients, families, and staff and others involved with the system, and responds by fully integrating knowledge about trauma into policies, procedures, and practices, and seeks to actively resist re-traumatization. Now, we developed a model that I'm just going to go through very briefly to guide our implementation of a holistic trauma-informed clinic. And I just want to say that this is a guide and aspiration. This is something we've just begun to do. And I just wanted to describe it to you so that this could be helpful to you or people you work with who are trying to create similar programs. So the model we identified has 4 core components. And its key innovation is focusing on trauma that includes both recent and lifetime abuse, as well as on provider well-being, recognizing that providers too have experienced trauma and stress. And I'm just going to go through each section very quickly. A trauma-informed environment is calm, safe, and empowering for both patients and staff. The second is screening. In a trauma-informed clinic, providers routinely inquire about both current trauma and lifelong abuse, as well as the consequences of lifelong abuse, including complex PTSD, depression, and substance abuse. And I think it's important to note that trauma-related information and interventions can be offered regardless of whether people choose to disclose their traumas, because oftentimes it's very hard to feel safe enough to disclose them. And finally, screening is directly linked to on-site or community-based interventions that address current and lifelong abuse. And the clinics will decide which responses can be provided through linkages with community partners and which have the resources to provide them on-site. And I would like to say that a lot of people and substance use counseling and therapy services are excellent, but for people with PTSD, there really needs to be expertise in PTSD and in people who have experienced intimate partner violence and other forms of lifelong abuse. And so what we're working towards is, even in clinics that do have mental health and substance abuse through linkages or on-site, helping those services be genuine trauma-specific and trauma expert in how they work. I did want to include one slide that describes our response to lifelong trauma. And again, this is a lot of people ask me, like, well, how do you actually heal from lifelong trauma? You can't really relive your childhood, and you can't undo things that have happened to you. And I just want to say that it is possible to heal from lifelong trauma. And I'm just going to list what's in black. Sorry about how complex this slide is, but it involves improving damaged connections. And so there's 3 basic ways to heal from lifelong trauma. And one is improving connections with others. And that's through trauma-specific individual and group therapy, like many of the ones that Vickie mentioned, like cognitive behavioral therapy, and peer-led empowerment, support, and leadership training, like what NANA does through the Positive Women's Network. The second part is improving physiological connections that have been disrupted by trauma. People genuinely change their brains and the physiology because of trauma. And the solution to that is trauma-specific psychiatry and physiological techniques, such as EMDR, the eye movement and desensitization and reprocessing mentioned by Vickie. And lastly, it's about improving connections with our bodies, which have been so disrupted by trauma. And that can happen through many ways, including body mindfulness-focused healing. And for many people, it's a combination of all these that really lead to full healing from trauma. I'd like to just mention one thing about political advocacy quickly. NANA is an organization of political advocates, and she brought me along with her into advocacy. And there has been a lot of advocacy at the national level to raise awareness about trauma in women living with HIV. And there was a White House presidential working group on the intersection of violence against women and girls, HIV, and gender-related health disparities. And because of the advocacy of many people, especially NANA and others, one of their action items is to develop, implement, and evaluate models that integrate trauma-informed care into services for women living with HIV. And now the new national AIDS strategy, for the first time ever, which is amazing to me, mentions the word trauma and dedicates at least a small part of it to helping women heal from trauma as a core element of HIV care. And this is a picture of NANA and me kind of in the background at the White House on Valentine's Day of 2014 at the release of this working group report, which was really exciting. And again, this is mostly to show the power that an individual activist like Nana and like you and like others can have by speaking out. Lastly, I would just like to talk about one final partnership that was so important. And this was with Rodessa Jones and the Medea Project. And the Medea Project is something that Rodessa developed in jails, where she would bring a group of women together, have them write stories about their life experiences, and then read those stories to each other, and then as a group choreograph those stories into theatrical pieces, which they would then perform publicly. And I partnered with Rodessa, and we got a grant, and she left the jails and did this with a group of women living with HIV from my program, and we studied this. And this is how I learned that it's possible to heal from lifelong trauma, that I saw women who were able to value their experiences, disclose in a safe environment to a group of trusted sisters, and then begin to disclose to a greater number of people, and heal. And I participated in this and studied this work, and this is what has inspired me to work with even people that I think many people would think would never be able to stop smoking crack or become housed, and instead believe that they can and become very healed and successful. And our study looked at the 5 impacts of going through this, and I'll just read them. One is sisterhood, the formation of deep, honest, and supportive relationships among group members. Then was catharsis, freedom from the burden of secrecy about HIV, childhood and adult trauma, and stigmatizing experiences. Self-acceptance, reframing and the understanding of what it means to be a woman living with HIV, normalizing life with HIV, and embracing a stronger and more positive self-identity. Developing safer and healthier relationships. And I think most importantly, gaining a voice, a sense of purpose and accomplishment as an educator and activist, and the skills and confidence to change the social norms that create trauma, stigma, isolation, and HIV risk. This was so inspirational to me, and I think these categories are what I look for in practically any of the interventions that we do, as what I'm really trying to achieve with any form of therapy or intervention here in clinic. So I'm going to end by saying, first, know this. This model that I'm describing, these services are aspirational. Very few clinics have these services in place, but there's an increasing awareness that trauma is important and that trauma is treatable. So in the meantime, what can you do? So stop and think about the connection between trauma and your own health, and realize a lot about who we are and what we do are because of things that happen to us, not because of things that are wrong with us. And I'll give just one example. Amphetamine was the first legalized antidepressant. People who are addicted to crystal meth hate being addicted to crystal meth, and people think terrible thoughts about them. But it's pretty obvious that people addicted to crystal meth don't want to be addicted to crystal meth and are most likely treating PTSD and depression. 3, get help in any way that is available and feels comfortable to you. And one key is avoiding isolation. Find peer groups, substance abuse groups, therapists, friends, anyone you trust, anything but staying alone. And if you feel comfortable, ask your providers if they have services to help overcome trauma and PTSD. And if you are experiencing intimate partner violence and danger right now, there is a National Domestic Violence Hotline that you can Google, this National Domestic Violence Hotline, and it's completely confidential and it's 24 hours, and here is the number for it on the slide, and that'll be available on the website from the WELL Project. So we have a poll question.
Hi. In the interest of time, we'll skip the poll question.
And you can skip my conclusion slide. So so I would just say, in conclusion, it's really, I'll just say people can heal, and that the problems faced by many women living with HIV can be so much more effectively treated if we have integrated behavioral, mental, and physical health care, and be more effectively treated if primary care becomes genuinely trauma-informed. And just from a provider's perspective, I'd just like to say a lot of providers are really stressed. A lot of providers have trauma themselves, trauma histories themselves. And if you're not getting what you need from your provider, or they're being really rushed and stressed, it's probably because they're being triggered and not supported. And a trauma-informed care environment supports providers for their own mental health, and I think can change the experience for both patients and providers. So thanks so much to all of you for being part of this webinar and for including me.
Thank you, Eddie, very much for an amazing presentation as well, and I think super informative and gives a lot of hope that, there's an initiative, and thanks also to PWN for helping spearhead and making sure that there is more places like yours that will be providing this type of care. So I am going to kind of skip through this a little bit, but the reason we included a couple slides around our 2014 survey is because we too, seeing that a lot of our resources are online, we have seen the power of kind of a community, especially through A Girl Like Me, and people blogging, coming together, sharing their experiences, helping people relate to those experiences. It's helped both the bloggers as well as people reading the blog to get some of these things out, as well as get feedback on that, and then have people who may feel isolated, who may be not out with their status, to read about things and help them feel less isolated. And so we've seen just kind of an organic evolution of people both blogging as well as being a part of the blog and that community to have a positive impact on their own self-care and quality of life. And so we're trying to both broaden the reach of that as well as measure that even better in the coming year. So anyway, so this slide here just shows a few statistics around, 58% felt more hopeful and positive about the future as being part of the Well Project's online community, and more self-care and more confident, more self-esteem. So I'm going to quickly skip that because we don't have that much time, but just to let you know, on that note, we are going to be launching our next survey in the coming weeks, and we really hope for anyone who has utilized our online resources, whether it be fact sheets to get information or be reading a blog or blogging or taking part in these treatment advocacy webinar series, to please take the survey and give us your feedback and help us improve what we do and expand the reach. So now I'm going to hand over to Arnetta Rogers, and I realize I need to, Arnetta, I think I might have just disconnected. Okay, Arnetta, can you hear me? So she is the Law and Reproductive Justice Fellow from PWN USA, and they are going to be providing a webinar tomorrow, also in honor of National Women and Girls HIV/AIDS Awareness Day, and that is going to be talking about a study they did that's securing the future of women-centered care. And we'll talk about, the importance of Ryan White programs and how you can get more involved in advocating to have the type of care that Eddie is describing across the U.S. So, Arnetta, are you there? I'm sorry if you can. Okay. Okay, we'll see if she comes on, but I'm going to keep going for the moment. But this is just a sneak peek of their some of the results from the study that they did around how, getting more information about how people can improve their ability to stay in care and assessing gaps in sexual and reproductive care. Okay. Okay, just one second here. I'm going to... Okay, Jenny, I promoted your microphone on your computer. Is that how you're?
Okay, can you hear us?
Yes, thank you.
Can you hear us?
Yes, I can.
Oh.
We can hear you.
Okay, good. Sorry, I've actually had the sound off because we had the phone on. Sorry about that.
Yeah, I'm sorry.
Okay, great. Thank you so much for having us and letting us speak to this really briefly. This is going to be a great follow-up to the conversation today as we talked about many of the disparities around mental health that women living with HIV are facing. So this research project, as you gave an introduction to, is a year in the making in which 14 women living with HIV were trained as community-based participatory researchers and collected data from over 180 women in 7 geographic regions, asking them, what things would improve your ability to stay in care. So the research was done in the context of the ACA implementation, the National HIV and AIDS strategy, and of course, as we move forward with Ryan White reauthorization and the president's renewed proposals to consolidate parts D and C of the Ryan White program. So the slide we have up here is just kind of these are two graphics that show some of the snapshots, some of the barriers rooted in economic insecurity of women living with HIV. And so we have, we'll discuss those barriers in greater detail, as well as around sexual and reproductive health care and, of course, mental health. And then, so if you could go to the next slide. Oh, sorry. So tomorrow we'll be hosting the webinar, and then following the webinar at 3 p.m., we're really pleased and excited to be hosting a Twitter chat discussing the findings from the report with Greater Than AIDS and the Well Project. So we hope you all can join. That's going to be at 3 p.m. Eastern, followed by the webinar, which is at 1 p.m. Eastern. That's going to be an hour and a half conversation where we'll, again, discuss the report findings, hear from the community-based researchers and as they share their experiences, and then continue the conversation for National Women and Girls HIV and AIDS Awareness Day on the Twitter chat. So hope to see you all there.
Great, thank you. And if you want to put the link to the registration for the webinar in the chat box, that would be great. I know people would love to get that.
Sure, I'll put it in.
Excellent. Okay, so I'm going to try and get to as many questions as we can. One of the questions that directly relates to what you just spoke about, Eddie, came from a provider and said, how do you keep good providers in the mental health field because of some of the issues if they're not in a trauma-informed care setting where that is? I mean, do you know of any strategies that help care providers in the field?
We've had the most success by partnering with mental health agencies that share our values. And we've been lucky because in a large metropolitan area, we can, there's multiple different groups of mental health care providers, and we can really try to build partnerships with certain individuals that understand trauma and don't disparage people for using substances and want to work with our patients and feel like it's a privilege. And so we just wrote a grant to work with an agency called the Trauma Recovery Center at San Francisco General Hospital because they're genuine trauma experts to supplement some of our services, which are already trauma-informed, but for the people who are experiencing PTSD and need very specific trauma therapy, these were really the only people that, these were some of the best people to do that therapy. And so one is to find grants. There's now grants from SAMHSA and other organizations that will help fund integration of mental health into primary care. Many hospitals are being incentivized to embed a psychiatrist or a therapist into primary care clinics, and I think it's just important to interview them if you can and find ones that are really that are good. And I guess in terms of retention, my dedication in running our program is to create an environment for our providers where people are safe. The providers are safe. Providers feel like it's a collaborative, non-hierarchical environment where they're compensated for the work that they do, and where there's a way to help them heal from the vicarious trauma that they experience working with so much trauma, and also the triggers for their own histories of trauma. And so it's about taking care of the individuals in our program. And I guess a lot of it just starts from the leadership. Like, I'm lucky to be leading our program, and UCSF's lucky to just let me do what I'm doing. But I think if your program doesn't have a leader that is really impassioned about this, I think it starts with convincing them that this is an issue that's worth attending to.
Great. Thank you. And one question from one of our participants and community advisory board members who is not in the United States, is in Africa. It was asking if it means when is she stressed or having mental health issues when she thinks about suicide in taking her life, and also the issues of addressing the lack of mental health care and services outside of the U.S. I mean, I know maybe that's not our presenter's forte, but I just maybe want to address the fact that, does that fall into a mental health category?
Well, I would just answer very sympathetically. I think living in Africa, especially, I've done work in Uganda, is very challenging sometimes. There's a lot of violence. It's very normal to have a lot of sexual violence in various countries. There can be a lot of homophobia, and there's a lot of stigma around depression and mental health and around HIV, both here and I think even more so in Africa. And so, I just want to acknowledge the woman who's asking this question for your strength in being on this call and for caring about your mental health and trying to learn about it and others, and surviving what is a very challenging situation in Africa. I'm really humbled by your experience and honor it. I would say that if anybody's having thoughts about suicide, I mean, I think some people do have thoughts about suicide and kind of know they won't kill themselves. But I think it's very important, if you're having thoughts about suicide, to talk to somebody that you trust about those thoughts, to help you not be isolated with those thoughts. Because the isolation can be so dark, and to help you really understand what those thoughts mean and help you stay safe. Because obviously, because you're on this call today, there is some drive to be hopeful, to learn and to lead. And I would think that it'd be very important for you to share those thoughts and with somebody that you trust, that you can hopefully find in your local part of Africa, and figure out if you are depressed. And need help with that. And there's also suicide hotlines that I imagine can be accessed internationally that Vickie mentioned. And if you can't find someone locally, I think you could call somebody on that suicide hotline and talk to them that way. But I would say it's important to deal with, because keeping that to yourself can be very dark and even dangerous.
Okay, thank you very much. Yes, I'm always reaching out. So one question that came through was asking about, are there special services for pregnant women living with HIV? And I for one, know there are, but I don't know, I mean, in certain places there certainly are, but Eddie, I don't know, or Vickie, Lynn, do you want to answer that?
So the simple answer is yes. Most major metropolitan areas have services for pregnant women living with HIV, and there is a hotline that is based at UCSF for providers in areas that don't have experts in pregnant women living with HIV, that the doctors can call from the hospital or from the doctor's office to get all the necessary guidance about how to be an HIV-positive woman and have children, and have those children be uninfected. And that is a virtual guarantee as long as a woman is in care. And you can even do that rurally and get guidance from this hotline at San Francisco General. And you would just have to alert your provider that there is a hotline that teaches you how to do that.
Great, thank you. And I know we've reached our time, and I don't know if Vickie and Eddie, you have a minute or two to spare to continue to answer a couple questions if people want to stay on.
Of course I do, but I just want to respect everybody else's time, and I can be here for as long as anybody wants. Okay.
So I'll pose a couple more questions. I just want to take 1 minute to note that quite a few people have asked if the slides from today's presentation will be available. We will provide a PDF version of the slides that you could download when we post the webinar recording and all the pre and post tests to our website, and that should be available tomorrow or Friday, and you will receive an email when that is available on our website. I also just want to quickly go through a couple of these slides on the resources. The Well Project has fact sheets and some slide sets available on some of these specific topics, and more information. We also have a link to Eddie's program at UCSF, as well as a link to Positive Women's Network, and again, the suicide hotline information. So I will, if you have to jump off, we understand. We'll also be sending out a link for the post-test, the post-assessment that is part of if you're interested in getting a certificate of completion. And so the other question, one question, I think it was answered, but I think it's worth just revisiting it it was slightly answered on the chat line, but someone had asked about what are the chances of someone living with HIV without meds.
So I guess, Vickie, I'll field this one. The person's asking, do people with HIV really 100% have to be on antiretroviral medicines, is I guess how I'm interpreting that. Mm-hmm. And there are some people who have an immune system that is very lucky and can control the virus without medications. And some people have a virus that is a very, what we call, unfit virus, like a virus that's not as strong as most of the typical HIV viruses. And so if you're one of those people, you can be undetectable or have a very low viral load without HIV medicines indefinitely or for a very long time. But that's less than 1 out of 100 people living with HIV. And unfortunately or fortunately, now that we have medications, for the 99 out of 100 others, at the moment, until we have a better immune treatment or way of treating HIV or curing HIV, which I actually believe is on the horizon, not immediately, but sometime in our lifetimes, 99 out of 100 people will need to, at some point, need to be on the antiretroviral HIV medications unless we come up with that cure or different form of treating it before people's T cells get low. And the other thing is we used to wait until people's T cells got really low to treat HIV because the medicines were just so toxic. And now we've learned two things. We've learned that waiting too long, people don't do as well. People get a lot of complications, both from HIV and from things that we didn't even realize were associated with HIV, like heart disease and kidney disease, if people's T cells get too low. And the medicines, especially the newer generation of medicines, are much less toxic. So now we're moving, even though I've been a skeptic of many things Western and many things biomedical for a long time, we're moving towards treating people with medications carefully much earlier than we used to. So I think the concrete answer to your question is for most people will need to be on HIV antiretroviral medicines until we get better treatments.
Thank you. So then another question was asked of, as our federal and state funding for HIV continues to decrease, what can we do from a state health department perspective to create and implement trauma-informed primary care models for women living with HIV at the clinical and community level? Be practical. But maybe we can point to ways that people can get involved in some of the advocacy around making this more available.
So I guess I'll take this again. So thank you for that question. So I think you're right. I think if you're interested in working with the PWN, Positive Women's Network, this is one of their core. They focus on a lot of things, including criminalization and other issues that are very important to the lives of women living with HIV. But one of their core missions is to get trauma-informed care disseminated throughout clinics. So one of the things that we're focusing on together is getting states and federal governmental agencies to require HIV programs to report information about PTSD and intimate partner violence and depression and substance use rates in their programs, so that those rates are measured and so that programs are held accountable to effectively improve them, coupled with more resources to programs to help them achieve those goals. And so you can have HRSA, which runs Ryan White, or state agencies require programs that receive funding to measure those outcomes. And I think just by measuring them, requiring programs to measure the outcomes, they'll realize how much trauma and substance addiction and depression are in their clinics. And hopefully then they'll awaken to how interrelated those issues are towards to HIV and well-being.
Thank you again. And this also is for Eddie. Someone asked if your approach gets shared with Canadian researchers with women living with HIV, or maybe.
Can you say that again?
Yeah. Sorry. This one is. The question, and I'm not sure if I got it complete right, is does your approach get shared with Canadian researchers, possibly, I think there's a word or two missing, that maybe who work with women living with HIV or focus on women living with HIV. So maybe Canadian? On a broader scale, is it shared outside of the U.S.?
Well, not only is it shared outside of the U.S., but some of the best research on trauma-informed primary care and then trauma-informed primary care in the context of HIV comes from Canada. There are researchers in Canada that are leaders in this on an international level. And so our research is shared with them, but I learn a lot from those individuals in Canada working on this particular topic.
Okay, and there was a clarification coming in that shared with researchers who conduct studies with women living with HIV. So
yes, we share information. I wish we had more personal interactions because we haven't. But I would say that some of the best implementation studies of trauma-informed care are coming from Canada. They're as far along as we are, if not further along. They're quite impressive. And so yes, we're definitely communicating by email and sharing our research findings. And I'm quite inspired and actually a little competitive with them.
That's always a good thing. And we all may be moving to Canada soon, anyways. Okay. I think that covers the questions that came through, and unless any others quickly come through the chat, I will just want to again thank our amazing presenters for really giving a great overview of the issues affecting women living with HIV and also more broadly people living with HIV, but especially women, and this model of care and having a provider who is so invested in addressing the issues that are coming through and in his clinic, and so we are very grateful for both of you and for all the participants and all the comments and all the work that the people are doing as advocates or care providers who are here today. So we're going to end the webinar now. I'll just reiterate that we are again going to send out a communication in the coming days that will provide a link to a web page that will have the recording of today's webinar so that can be shared with colleagues and friends. Also the pre and post test links, a PDF of the slide set, and some other links to helpful resources on this topic. And then also keep an eye out for the survey that I mentioned in the coming weeks, as well as information about our next webinar, which is going to be a community update from CROI 2016. So we hope you all can join us at that as well. Okay, and if any other questions that weren't answered, please feel free to send an email directly to the Well Project, and you can just reply to one of the communications that you get via the webinar. Okay, thank you, everyone. Anyone else have any closing words?
There'll be more. I'll for the Canadians on the webinar. I'll give more contact to the Well Project. There's a woman named Catherine Klassen who's just a trauma hero up there, and there's a guy named Reed Simonachek. I'm totally not pronouncing his last name right, who's doing a lot of work with HIV and trauma, and I'll give contacts for both of those individuals to Krista to put on the resource list after the call.
Excellent. Thank you again, everyone.
Thank you. Bye-bye.
Bye.
Bye-bye.
Bye, thank you.